Hello everyone, this is Dan Pawlus, Senior Customer Marketing Manager at HealthStream, and we're here in the HealthStream headquarters. I recently had an opportunity to sit down with Kelly Aldrich, the Director of Innovation and Associate Professor of Informatics at Vanderbilt University, and we were able to talk about interoperability. She has some fascinating insights to share. What about the need for better tech? I think about things like big data is thrown around a lot, cloud technology, AI. Where are you coming out with that in your own kind of synthesis, and what are you teaching, in the classroom to get us further down the road on that?
Yeah, so I also had the privilege and the honor to be, when I worked at HCA, to be the inaugural Chief Nursing Informatics Officer. And so that role was over 180 hospitals. And so I was exposed to a lot of technology. So coming from the bedside and really, being that person, the interoperability, into more of a leadership role, what I found really pretty consistently was that they were telling me what technology I needed. So companies would come and they would say, "This is how you would use our product."
It was a vendor saying, "We think
yes,
you need
a vendor partner would be
yeah.
telling me how I needed and why was this important. And at one point I just did a timeout and I said, first of all, I'm not ever going to go into another meeting unless you have a nurse on your team. So I just refused, because the impact of that is that they were not understanding the workflows that impacted the usability and the adoption rates, because there were a lot of missing pieces that they hadn't worked out.
And that gets to the whole span of control thing and the horizontal workflow, which is so different in nursing than other places.
It's so different, but it's not just the word nursing. When you go into nursing, you can be a critical care nurse, you can be an ER nurse, you can be a perioperative nurse, you can be a hospice nurse. Any sort of nursing brings all of its challenges to the table. So this was a problem. And so what I did was, in addition to saying that I wouldn't go into any more meetings unless, it just saved a lot of time, but I also said, I need to make my own roadmap of what was easy to use, what was useful and satisfying for the nurses to be able to have the right tools that they needed, so that could improve their workflow. And so I did a call for innovation across the company. And I asked if they could just give me little 3x5 cards of any time during 2 shifts that something really ticked them off. What could you use? And it was amazing. I had over 800 responses come back, so then I partnered with some students who did the data analytics for me, and we came up with 3 things. They said, make me mobile. So,
and that's a generational thing in part too, right?
Well,
is there an expectation of just being more mobile?
Nurses are mobile knowledge workers, right? They're constantly moving from room to room. They need the data.
Literally on the move.
Literally on the move, right? Clean up the electronic health record, get rid of the stupid stuff that really doesn't impact or measure to the patient's care.
And when you say that, you're talking about the paper records to digitize, or more than that?
In the digitization piece around documentation, the efficiency is very poor. So there's nothing like if I were to say, her name from the tablet and say, could you look this up for me? Or I guess when I was a practicing nurse, I used to imagine that there would be this nurse in the wall that I could just call out what was going on. Nothing like that existed. It doesn't exist. And people could say, we have natural language processing and we have sort of tools like that. But, picture 4 clinicians around a bedside. When someone were to come out of having open heart recovery, you're titrating drips, you're hanging blood products. These people are in a kind of a constant code blue effect, and you have so many people that are constantly doing things. I can remember when I was working in one hospital in San Diego, and I had a patient come out of the OR very, very, very sick. This went on for about 7 hours. Needed to be back in the OR. They were bleeding and so forth. And after they finally did go back to the OR, I thought, I don't have one piece of this documented. So how can I?
Real time, right?
It was real time, and the realization was I didn't have an ability to just call out what was going on. We titrated the epinephrine. We just pushed atropine. We just hung 2 units of blood. We're just the normal things. So when you talk about clinician burnout, this is really not that hard. I've had many tech guys tell me it's not a technology problem. It comes down to a policy and financial. where the proprietary siloed data, we don't have that common infrastructure to seamlessly exchange data.
Right.
So they're still competing on that versus allowing us to innovate on top and giving the right tools to the clinicians to be more efficient and effective.